Welcome to the lecture series on vitamins and nutrition. As a continuation from previous session, we are going to look into the mechanism of action of vitamin D in detail. And in the previous session, I explained you about the role of nuclear receptors, and since vitamin D receptor happens to be a nuclear receptor, we were looking into how the activated version of vitamin D could go and bind with the nuclear receptor vitamin D. So today in this session we are going to look at a little more into the aspects of vitamin D mechanism of action. So I'll continue from the point where I had explained in the previous session. So this is basically the vitamin D receptor. So vitamin D receptor is actually given notation, what we call it like NR1 capital I and 1. So it's like 1I1, NR1I1, which is nuclear receptor subfamily 1, group 1, member 1. Because you do have a wide variety of nuclear receptors which have been characterized, and it's interesting to note many of these nuclear receptors are called orphan receptors. So what do you mean by orphan receptors? Because something like I want you to imagine this concept of a lock and a key. So for every lock there should be a key, and if you imagine the receptors should be the lock, and there should be a ligand which acts like a key. Now if you could have a lock without a key, then the lock is called a orphan lock, so something like that. So a nuclear receptor is basically a receptor which is already there in the cell exhibiting some particular function, and people actually discover these nuclear receptors as the vitamin D receptor. Many nuclear receptors of that particular category are already there in our system. Now when there is an exogenous ligand taken as part of a dietary supplement, or maybe a chemical, what we call it like xenobiotic, something that goes inside our system, when they go and bind to any of these receptors, only then we become even aware that such receptors exist in our body. So many of these receptors have been characterized by the use of external ligands, or ligands which have been taken from exterior, like as part of a dietary supplement, or maybe a drug or a chemical that enters and brings about a change. Later, once they discover or characterize a receptor, then they look for endogenous ligands. So if there is a receptor, then it means there is already a ligand available for the receptor which is part of a physiology, and only this exactly makes sure that this ligand, which was originally an endogenous ligand, goes and exhibits its function through this receptor. But in many cases, such ligands, endogenous ligands, have not been fully elucidated. So if any receptor is going to be that way, and if it doesn't have an endogenous ligand, then it's simply called an orphan receptor. So vitamin D receptor can also be called a kind of orphan receptor, but the endogenous ligand being vitamin D. So this makes us a clue. So whether vitamin D is already synthesized in our body, yes, to some extent, and that's what we have been telling again and again, that the skin is the source for vitamin D synthesis, and we have seen in the last session how it gets activated from liver to kidneys, and finally the 125 dihydroxy vitamin D derivative, which is the ligand for VDR. Okay, so look over here. This activated vitamin D is basically called as calcitriol. Okay, because it has 3 hydroxy group, you call it calcitriol. So I want you to look at the structure, because it's quite interesting when you study the structure and then associate the structure and then study based on that. It gives you a better insight. You see over there, there is an hydroxy group here, there is an hydroxy group here, and there is one more hydroxy group there. So that's why it's called trihydroxy or calcitriol. It ends with that name. Now we are going to look at how calcitriol is going to exhibit its function. Now this is the receptor, and now look at this. There is what we call it like hormone response element, and hormone response element is a DNA sequence what we have seen earlier. Now there is something very interesting that happens over there. So once vitamin D binds to vitamin D receptor, it forms a heterodimer with the retinoid X receptor. Okay, so the scheme what I gave in the previous session was about how a general nuclear receptor, when it's bound by a ligand, proceeds and goes inside the nucleus and activates a set of transcription factors. So this is the scheme I gave you to understand. Now we are going to look at specifically with respect to vitamin D. So when you look at that way, so you get this structure. Here you have vitamin D, basically the semi-activated version, 25-hydroxy vitamin D derivative, which is bound with DPB. So what is this DPB? It's vitamin D binding protein. So vitamin D binding proteins help in the transportation of vitamin D inside the cell. Now you could consider this to be the cell in the kidneys, or the cells that help in regulating calcium metabolism in the kidneys. So as I've told you earlier, they have 1-alpha hydroxylase. Now this goes inside, and now the 1-alpha hydroxylase adds one more hydroxy group, and now this calcitriol goes over there, and can you see there the retinoid X receptor, what we call it like RXR. So RXR, which is basically 9-cis retinoic acid. So 9-cis retinoic acid bound with RXR, retinoid X receptor, together they form a heterodimer. So if you recollect, I told you it should form a dimer. The dimer could be homodimer or it could be heterodimer. So when you say heterodimer, you do have two different proteins interacting in a complementary fashion. So that's what happens over here. So you have a heterodimer, and the hetero component of the vitamin D receptor happens to be RXR, retinoid X receptors. This tells you why vitamin D is very closely associated with vitamin A. So in fact, vitamin D deficiency and vitamin A deficiency are synonymous, and mutually you could see some kind of deficiency symptoms associated with either of them, because if vitamin A is not there, this homodimerization may not be possible, and if vitamin D is not there, again this homodimerization is not possible. So that way most of the preparations, even supplements if you consider in food industry and in the food preparations, you always simultaneously give vitamin A and vitamin D together, probably to encourage the mechanism by which they are going to get elicited and the way how they are going to play a role in calcium metabolism and all associated metabolism. So you see over there they produce mRNA, and what is this protein? You have calbindin. So calbindin is a calcium binding protein. Calcium is an extremely important mineral inside the cell, because calcium is stored in the endoplasmic reticulum, and calcium binding is extremely useful the way how muscular contraction happens in the actin fibrin contraction. So probably that's out of scope in this subject as we are doing, but I want you to be aware that calbindin is that particular protein which regulates calcium transport within the cell and also ensures calcium availability in the sera for a wide variety of functions. Since calcium is so important for muscular contraction, smooth muscle or cardiac muscle or a skeletal muscle, any deficiency in calcium can lead to paralysis. Okay, so you see, eventually it can lead to paralysis and neuromuscular degenerative conditions and all sorts of other associated complications connected with calcium deficiency. Now we are going to look at one more aspect before we finally wind up with the mechanism. So you see there what we call it like not only regulates transcriptional responses, but is also involved in microRNA directed post-transcriptional mechanisms. So what do you mean by that? So this is a very recent topic, microRNA directed post-transcriptional mechanisms. Probably we may not be able to cover the entire scheme of microRNA directed post-transcriptional mechanisms, but I just want you to highlight little bit of what exactly this is all about. there is a wide variety of mechanisms and schemes concerned with gene regulation. And in the recent times, gene regulation is a hot topic, because the way out, because earlier in the days when people were trying to understand the molecular biology of cells and various related functions, people were more concerned with one gene, one protein hypothesis. Then they came to know, no, it doesn't work that way. There are lots of spliceomes and many post-translational modifications playing a role. And now people have come to realize those non-coding regions in the DNA have more role to play in regulating the transcriptional region, the region which is exactly responsible for producing protein. So this one, what we call it like microRNA directed post-transcriptional mechanism, has something to do with gene regulation, the way what kind of elementary substances which are involved in the expression of a protein concerned with cellular metabolism. Okay, so VDR, the vitamin D receptor, can act like a molecular switch in the DNA and regulates quite an array of cellular functions. So that's why vitamin D deficiency really creates a havoc in the cell. So now we are going to look at some more aspects, what we call it like the the different ways by which you can create a regime for vitamin D therapy. So like you say 1-year-old, adults and adolescents, adults, then patients, and then with different categories. So you see there the vitamin D supplements, you have a weekly regime, you have a daily regime, then you have a therapy, and then you have the maintenance therapy. So if you look at it, you can actually summarize, in many cases the daily regime for restoration of vitamin D deficiency, you have a span range from 1000 international units and goes up to 10,000 international units. You have to be like really particular about the dosage, because as I've told you earlier, vitamin D deficiency can actually cause major problems, but on the other end, trying to supplement them can also lead to hypervitaminosis. So the range is like 1000 to 10,000 units, but somewhere it fluctuates between 1000 to 5000 IU units. Then the weekly regime, in other words, you target how much maximum the person needs to be supplemented. So for a week period, you can have like 50,000 units, and then for a month it goes, and then once you stabilize the availability of vitamin D in the diet, and once you are trying to reverse the symptoms, deficiency symptoms, you put them on a maintenance dosage of 400 to 1000 units. So most of the formulations and preparations, when you check up in the commercial setup, they actually sell tablets or capsules, mostly capsules, which is white soft gelatin capsules, which can give you somewhere around 200 to 400 international units. So like if you want to have 1000, yeah, you can supplement with more capsules. And some of the natural sources, I would say, egg being an excellent source, and the other source being fish oils. And for people who don't have affinity, as I've told you, like vegans who cannot take egg or fish, can always go for mushroom related preparations. Now we are going to look at how we monitor. So vitamin D deficiency is basically monitored in terms of endocrinopathy. So endocrinopathy is any kind of abnormality or pathogenesis connected with hormone, that's endocrinopathy. So this reflects in bone loss. So mineral density is like really a good concern for you to monitor. So as I've told you earlier, so amenorrhea. So as I've told you, vitamin D deficiency would have a major impact on hormonal changes. So then bone mineral density can actually also be related with osteoporosis and osteomalacia. Okay, so in such cases, vitamin D supplements are generally recommended along with calcium, because they would have been taking calcium for quite a long time, but the calcium would have never found their way inside the system. So now when you want to supplement them with vitamin D, it's more logical that you give calcium, at the same time you also provide vitamin D. So this is a power combination. Calcium and vitamin D together really helps in reversing most of the side effects. So Look over here. Here you have a dual replacement therapy. So for hypocalcemia and I would say vitamin D. Now you have to look for certain features. See, for example, in dual replacement required where there is a severe deficiency accompanied by hypocalcemia leading to secondary hyperparathyroidism. So I want you to look at this word, secondary hyperparathyroidism. So parathyroidism is basically hyperparathyroidism is excessive production of parathormone. As I told you in the beginning of previous session, that parathormone, calcitonin, vitamin D are all linked with calcium metabolism. Now secondary is basically because of this calcium deficiency, which is creating a kind of a negative feedback, more amount of parathormone would have started secreting into our system. So this secretion eventually leads to a transient benign state of hyperparathyroidism, which is like secondary effect of the primary deficiency concerned with hypocalcemia. So any hypocalcemic state can actually cause what we consider as secondary hyperparathyroidism as a means by which to restore the loss of calcium in circulation. So when we try to manage the osteoporosis, especially among elderly, we need to take into consideration all these features. We can look at calcitriol. Actually you have two preparations, alpha calcidol, which is 1 alpha vitamin D, the activated version, and calcitriol have no routine place in the management of primary vitamin D deficiency. So what do you mean by this? So this is basically the real activated version of vitamin D is not like directly given as a supplement. Only in severe cases, in acute cases, it's recommended. Mostly we want to like restore the pathway. So you give that precursor vitamin D and you allow the system to make the activated versions. So when we have this done, so there are conditions where, for example, in renal diseases and liver diseases or hypoparathyroidism, in all these three cases, people lack or they are, I would say, incapable of converting the vitamin D to the active form. If their system is already capable of converting vitamin D into the active form, you better don't give them alpha calcidol or calcitriol. So this we reserve only in cases connected with liver diseases, renal diseases or hypoparathyroidism. And in all these three cases where they do not have ability for activation, you give directly the activated form. So whereas people who are already healthy, giving a precursor form is more than enough for vitamin D deficiency, and this would eventually kickstart the vitamin D associated mechanism. So this is really good because whenever you try to supplement with any activated version, it's something like you can, you are trying to give testosterone in case with deficiency, and if there is an organal disadvantage, I would say ectomy of an organ, then you give a supplement of a steroidal hormone, it's acceptable. Whereas if the glandular structures are already there and you try to supplement them, this will give rise to unnecessary negative feedback hazard. I would call it like it will really screw the pathway in which the pituitary axis would control. Same thing can happen for vitamin D because as I've told you or I've been telling you from the beginning that vitamin D and vitamin A are unique vitamins with a hormonal property. So when we give a direct active version, we could really throw haywire the hormonal pathway that basically happens, and that can lead to severe complications. So in such cases, we reserve the activated versions only for special cases as I've told you, the renal disease, the liver disease and the hypoparathyroid cases. Now how do we monitor after you start with the deficiency therapy? Like you look for the bone and the renal profile, how their response is there. So what do you mean by like renal profile? Because kidneys are essential organs in reabsorbing calcium. So we don't want to lose all the calcium, and most of the calcium is recycled. Anything that's not absorbed and the calcium which has been eliminated by kidneys during the normal filtration process, everything is reabsorbed and everything is utilized back. So if kidneys are not in a position to really restore back the cycle, then that's an indication that the therapy is not like really successful, and we need to look at in ways of improving the supplementation dosage, or probably look into other complications associated with prolonged or a long term vitamin D deficiency. So you see there, you establish the vitamin D replacement and you optimize the therapy accordingly, and then here you have effective strategies, what we call it like the recent recommendations, like put them on a maintenance dosage of 200 international units of vitamin D per day, and that will be the best one. So any natural food preparations that we also monitor can also look at 200 international units vitamin D. So either the person can be substituted if it's on a natural note, egg yolk supplements, or recently people also have come up with isolation of vitamin D rich layer, what we call it like yolk oil, which is also an excellent source of vitamin D. So, and again we need to consider special categories like pregnancy, nursing mothers, and in such cases we can always start with a loading dose, what we call it like you give sufficient amount of vitamin D and put them on a maintenance. So here you have the international agencies IOM, okay, their recommendation says that 200 international units per day is really a good data, and they say 50% of women of the reproductive age have low vitamin D. So it means like generally speaking, folic acid deficiency would be very high for pregnant women, because there is a sudden surge in the demand for folic acid, and it's been supplemented by making it compulsory or mandatory for them to take folic acid and iron supplements. So similarly, women of reproductive age, the food preparations or the food recommendations that we give as dietitians should include vitamin D as a regular supplement. So probably if they are having access to vitamin D rich food, it can be recommended, or else mandatory dose of vitamin D regularly taken would really encourage the overall hormonal development. So we also need to consider for women who already have vitamin D deficiency and who are preterm and who have delivered, we need to consider giving vitamin D supplements. So nowadays the trend is the newborn neonatal, we supplement with vitamin D drops to encourage the better developmental functions in the neonatal. So it's mandatory, and in most cases when vitamin D measurements are not being done in pregnant women, we recommend taking vitamin D drops to infants to as a precautionary note, as a prophylactic note, to prevent vitamin D deficiency related complications. So here we look at it in what all way we can supplement. As I've told you earlier, the neonatal supplement with vitamin D can also be taken care in addition to supplying them with calcium. And here we have, for people who are a greater age like elderly generation or geriatric population, we recommend them with adequate exposure to sunlight. So this is the first step in vitamin D deficiency conditions. So providing adequate exposure to light, and then providing a diet that would be good enough for these fat soluble vitamins to be absorbed. So we should also take into consideration, because these vitamins being lipid soluble, you need to take special precaution, because the diet, if it doesn't have lipid rich source, would be an unsuitable diet for the absorption of these vitamins. So it's not only the supplement that we give, we should also ensure that the diet is amicable in allowing vitamin D and vitamin A to absorb effectively across the gastrointestinal tract. So that's why all these fat soluble vitamins, the general ADME requirement, absorption, distribution, metabolism, elimination criteria, focusing on absorption, when we say, we always recommend the diet should be rich in lipid rich food, at least at the time of intake of these dietary supplements, especially vitamin D and vitamin A. So finally, coming to this point, who would be at risk to vitamin D overdose? So here we have anyone who are taking vitamin D supplements should monitor carefully. So probably it would be advisable to have a periodic monitoring of vitamin D when they are already under supplement. Yes, if the clinical symptoms have improved a lot, that will be wonderful as for children and elderly, and especially for people who have been put on a loading dose and who are on a maintenance dose of more than 10,000 international units. You should always consider how much amount of this vitamin D is available in circulation. So time to time monitoring for vitamin D for people who are already on the therapy of vitamin D supplementation is essential. And here this point is quite important to notice. There are cases of industrial accidents, especially in the refinement business, especially preparation of oils in refinery centers where they are fortified with vitamin A and D. Any accidental industrial contamination or probably dosage of excessive amount of this vitamin A or D can also lead to a mass overdosing of vitamin D in all the products. Yeah, obviously you do have a quality control parameter which is done, but in any case we need to closely monitor in fortified foods to ensure not too much of vitamin A or D is added. Sufficient enough that would compensate for deficiency would be always good on a long term basis. So suppose if you look at what would be the health hazard or risk connected with vitamin D, here we have nausea and vomiting to start with, and then we have overall weight loss. So if you closely look at it, most of the side effects resulting from overdose of vitamin D are much similar to the one that results with deficiency. So it means what we are trying to say over here, vitamin D strikes a very delicate balance. Excess or less in any case can be really hazardous, but overdosing can happen in only special cases. So it's much easy for us to monitor overdosing, whereas overall deficiency of vitamin D is happen to be a common phenomena in the places, especially in the developing countries. Thank you.